So, good morning, everyone. It's a great pleasure to be here today to discuss the benefits of early intervention in atopic dermatitis and how can we change the course of the disease. This presentation is sponsored by Sanofi. In this presentation, I will be discussing the cumulative life impact of uncontrolled atopic dermatitis and the importance of early intervention, disease control, and the potential for disease modification. I will also present new data on the systemic burden of atopic dermatitis in children, adult, and older adults, and the need for early intervention. As we all know, children with uncontrolled moderate to severe atopic dermatitis suffer from daily itch, frequent relapses, sleep disturbance, which can affect their school performance, leading to poor school performance. They are also at increased risk of atopic and non-atopic comorbidities such as poor bone health, mental health disorders, and susceptibility to skin and systemic infections. So atopic dermatitis is not confined to the skin, as we previously thought, but it's a chronic systemic disease driven by type 2 inflammation. Type 2 inflammation is exacerbated by Staph aureus, which release type 2 inflammatory mediators and pruritogens, and those pruritogens and inflammatory mediators stimulate itch, increased risk of flare, and increased susceptibility to other cutaneous and extracutaneous infections. As you can see from this figure, patients, the proportion of Staph aureus positive skin swabs taken from atopic dermatitis patient was higher in patients with severe disease compared to those with mild and moderate disease, and it was also higher in lesional compared to non-lesional skin. So atopic dermatitis severity is directly correlated with the Staph aureus colonization and the presence of other bacterial and viral infections, as you can see from those pictures. In atopic dermatitis, skin barrier dysfunction allow transcutaneous entry of allergens and subsequent potential sensitization. This can trigger atopic dermatitis flare and can increase the probability of the patient to have more allergic diseases such as asthma, allergic rhinitis, and food allergies. This is supported by PEDISTAD and EPICARE studies. In PEDISTAD study, which included around 1,300 children aged 12 years and below with moderate to severe atopic dermatitis, it's been found that 61% of those children have at least one coexisting type 2 inflammatory disease. The most common was food allergy, accounting for 58%, followed by allergic rhinitis, asthma, eosinophilic esophagitis, allergic conjunctivitis, and nasal polyps. In EPICARE study, the percentage of preschoolers and infants who reported at least one type 2 inflammatory disease besides atopic dermatitis ranged from 76% to 94% with mild disease, 80 to 99% with moderate disease, 88 to 100% with severe disease. So this tells us that children with severe atopic dermatitis are at increased risk of having another atopic disease. When it comes to non-atopic comorbidities, pediatric patients with atopic dermatitis have a higher prevalence of mental health disorders, including ADHD and depression, as at all ages compared to controls. And the severity of AD correlates with increased risk of mental health disorders. The most frequently reported disorder in this national survey was ADHD, followed by conduct disorder, and anxiety, depression, and autism. So children with severe atopic dermatitis are at increased risk of mental health disorders. They are also more likely to have decreased bone mineral density, increased risk of fractures, and reversible growth impairment. And the potential contributors include early onset of atopic dermatitis, chronic poor sleep, corticosteroid use, and the effect of chronic inflammation on bone turnover. Atopic dermatitis in pediatrics negatively impacts the parents and caregivers of the patient as measured by Dermatitis Family Impact Questionnaire. It's a questionnaire that assesses the impact of eczema on the patient's life and the family lives. And it has 10 domains, including feeding, family sleep, family leisure, and shopping, and so on. So data from EpiCare shows that as the severity of atopic dermatitis increases in the last column, I have no pointer. So as the severity increases in the last column, you can see that the impact on the family also increases. So to wrap up, atopic dermatitis often precedes atopic diseases. The skin disruption allows transcutaneous entry of allergens, putting the patient into a risk of developing other atopic comorbidities and even the non-atopic comorbidities. So this tells us that early intervention focused on reducing systemic type 2 inflammation in the initial stages of atopic dermatitis may reduce the likelihood of future development of other comorbidities. Now I will discuss the importance of achieving disease control in adults with moderate to severe atopic dermatitis. As we all know, atopic dermatitis usually starts very early, between 3 months and 2 years of age. 60% of those patients can go into complete remission before 2 years of age. However, 40% can continue to have disease till adolescence or adulthood. This is an example of very early onset atopic dermatitis diagnosed at the age of 6 months. Many adults with atopic dermatitis have had their disease since childhood, as I previously mentioned, but it may also develop into adulthood. And this is an example of a patient diagnosed for the first time with atopic dermatitis at the age of 21. Treatment of atopic dermatitis should meet both patient's goals and physician's goals. The most important patient's goals includes preventing flare, itch, and to have good sleep and better quality of life. From the physician's point of view, the definition of disease control is defined as achieving clear or almost clear skin with minimal disease activity, such as achieving EASI 90 or EASI 100. 59 to 78% of patients with moderate to severe atopic dermatitis in real-world studies had at least one atopic comorbidity. So, which one is the pointer? This one? Yeah. Thank you. So again, 59 to 78% of patients with moderate to severe atopic dermatitis reported at least having one another atopic comorbidities. In this cohort study, you can see that asthma was more likely among patients with atopic dermatitis than those without atopic dermatitis, and asthma was more prevalent in those with severe atopic dermatitis compared to those with mild or moderate disease. Patients who have both asthma and atopic dermatitis were more likely to have asthma-related hospital admissions and asthma exacerbations. Adult patients with atopic dermatitis have increased incidence of anxiety and depression, and the possible risk factor that contribute to the anxiety or depression include sleep loss and systemic corticosteroid use. Adult patients with atopic dermatitis are also at increased risk of having cardiovascular events such as pulmonary embolism, myocardial infarction, deep venous thrombosis, and stroke. They are also at increased risk of poor performance and productivity. Adults with moderate to severe atopic dermatitis lose at least 9 hours of work productivity every week. However, adults with severe atopic dermatitis lose an average of 19 hours of work productivity every week. So as you can see, the higher the SCORAD, the higher is the adjusted overall work impairment. So those are patients with higher SCORADs, and those are patients with low SCORADs. So atopic dermatitis burden is cumulative, starting with type 2 inflammation and expanding over time to functional, psychosocial, and systemic consequences. So this emphasizes the importance of early intervention, which is crucial to prevent the cumulative life impairment. So far, we've covered atopic dermatitis in children and in adults. Now let's focus on practical consideration in older patients with atopic dermatitis. So when you have a patient with late onset atopic dermatitis after the age of 60, we should consider other differential diagnoses such as cutaneous T-cell lymphomas, paraneoplastic dermatomyositis, toxicoderma, and bullous pemphigoid. Evidence suggests that older adults with atopic dermatitis have more active disease compared to adults and children. So they have more activity of the disease. Patients with or older adults with moderate to severe atopic dermatitis are at increased risk of osteopenia, osteoporosis, decreased bone mineral density, and fractures. They are also at high risk of cardiovascular events because studies have shown that adults with atopic dermatitis have significantly greater vascular inflammation as indicated by increased endothelial-driven microparticles compared with non-AD patients. The incidence rates of MACE, venous thromboembolism, DVT, and pulmonary embolism are higher in older than in younger patients with atopic dermatitis. Older adults with atopic dermatitis also at increased risk of dementia, Alzheimer's disease, as you can see from the figures compared to middle-aged and adults. So the possible mechanisms may be because of chronic inflammation, oxidative stress, sleep disturbance, psychological distress, and reduced quality of life. Sleep disturbance impact older adults patients with atopic dermatitis to a greater extent than younger adults. So when treating older adults who are above 60 with atopic dermatitis, we must consider the polypharmacy, the drug metabolism and interaction, the coexisting atopic and non-atopic comorbidities, their renal function, their ability to self-administer medication or their need of assistant, and the functional independence with cognitive ability. Individuals on multiple medications had more severe atopic dermatitis, poorer disease control, increased days of flare, and increased hospital visits for atopic dermatitis. It's very difficult for them to apply topical creams. They can be time-consuming, difficult to apply. They may have stinging and burning sensation. And in general, the mortality risk was increased in individuals who consume at least 6 medications or more compared to non-medicated older adults. So this is Mohammed, is a 1-year-old boy presented with recurrent infected eczema and 2 attacks of eczema herpeticum needed oral acyclovir. And he has been on dupilumab for 1 year and his EASI score is 100. This is Maryam, a 10-year-old girl presented with severe eczema involving almost 90% of her body surface area. And as you can see, she has clear skin after 3 months of dupilumab treatment. This is Jenna, a 60-year-old lady presented with atopic dermatitis affecting the whole body. Hand and foot eczema was the most disabling, preventing her from cooking and taking care of her bedridden boy. So these are her images before and 4 months after dupilumab. So in conclusion, atopic dermatitis is a chronic systemic disease in which type 2 inflammation impacts both skin and other organ system, leading to cumulative life impairment. Atopic dermatitis presents unique and overlapping burden in pediatrics, adults, and older population. The cumulative impact of systemic inflammation emphasizes the importance of early intervention regardless of the age group to stop the burden. Thank you very much. Any questions? No? Thank you.
Thank you.